Professor Toshiro Ozakasi from Washita University, and he is a faculty for the human sciences. We have Professor Shumon Chakraborty, and we are very lucky to have him because he will really give an very holistic perspective how digital health can be really fitted in Sundarban context. He is the head of School of Medical Sciences at IIT Kharagpur. And finally, we have Dr. Priya Balasubramaniam Kakkar, who is a researcher, a public health scientist with Public Health Foundation of India. So we will be getting the virtual speaker towards the end of the panel. And so we start with Shujoy. Like digital health, it needs a human face also because it's for the human. So when you started way back, you know, like digital health ecosystem is really now fit because we remember when National Health Mission started in 2005, digital health people used to think that feeding the data, health data into one portal, that is digital health, because still we used to go to the ministry and ministry, oh, we are doing digital health. So from there we have moved to artificial intelligence, those aspects we are talking of. And I think all this thing possible was made possible use the smartphone came, it was more affordable. We have cheap data also is there. The community health worker became proficient using, you know, the smartphones. Those, you know, that initial hitch or that thing, how would you say in English, that thing that was removed from using the tablets, the smartphone and all. So here, Shujoy, when you started your journey, what was the acceptability in the community when it comes to, you know, it is, we are used to going to a doctor used to take our pulse, read our pulse, give us medicine, show your tongue, all this thing. When you talk of digital health, telemedicine, sometimes that human touch is not there. So how do you think the communities, particularly I would say semi-literate, who believes in traditional medicine, how they're coping with it, how they are accepting the whole new approach? So
Yeah, I think if I take a few years back when we started and we were, you know, objective has always been that how technology can become an enabler to healthcare. But unfortunately, we have seen technology playing a key role in many areas, be it telecom, finance, and other things. But when it comes to healthcare, most of the technologies has been built around the businesses. Like for example, when a patient is walking to a hospital, you have patient registration billing, whichever happens, and when the patient is walking out of the hospital, the patient loses all contact with the doctors. So for us, when we started our journey in 2010, and we were trying to push technology, leave the communities, leave the health workers, even the doctors were not very keen to adopt technology. They were pretty much comfortable to, but over the period, we did a research which was in partnership with University of Michigan, and in that we had the objective that we had to carry out the entire journey of the pregnant mother in terms of capturing the vitals, entering the data into the platform, and we were trying to figure it out. Is it indeed possible to train these health workers to, over the period of just few months, it just simply reversed, wherein they were able to capture the data on phone way more faster than the tablets and then on the paper. How that happened? Initially, when we're trying to push through the technology, for us being technology guy, I know when we are designing applications, being sitting in the labs and others, and even Kevin would agree with that we technologists think on designing solutions in a very different way. Like we are nerds in a way. We always think that the amount of features, functionalities, and trying to make the whole application very, very sexy, it's kind of in our DNA as a technologist. It's in our DNA. But being on the ground, what we have understood that all that matters for the community and for things to really work is the solution has to be robust. It has to be very, very user intuitive, and it has to be acceptable and adoptable by the communities. Unless and until the communities are able to accept that, they will not do that. Just to give a quick example, Linux has way more power-packed features than Windows probably. But the acceptability of Windows is way more than Linux, is all because the simplicity of its that how it could be used. So similarly, in this case, because iCure's technology and healthcare are both sides of the same coin, whatever challenges that we were seeing on the ground, we were able to quickly capture those challenges and bring back to our team to say that, okay, this thing is working and this is not working. For example, the simple gestures, simple swipes, which we have designed in the applications may be very obvious for us, but it is not so obvious for them. Even the simple, the texture of the skin, for the people who are working hard on the ground is different than the people who are staying in the urban areas. Even those textures, because of that, normal swipes, normal touch, or the GUI design does not simply work. And even this is around 2015, wherein the smartphone penetration, especially in the villages, was abysmally low, which meant that many of the health workers who are just actually, they are village women and they have never seen a feature phone, let alone a smartphone. I'm talking about that period. How do you imagine that they are going to use a complex application on the phone and interviewing the pregnant mother, entering the vitals, and making it possible? For several months, it was extremely hard, and we thought that it is near impossible for us to really think of such kind of a wild idea. But over this period, what we have understood is that we were able to figure out some brand champions. We were able to say and get up that yes, I can definitely come and see if it can really work on that. And through these brand champions, when these people or these women leaders within the communities were able to adopt such solutions, we were able to see quickly peer-to-peer learning, meaning that the others were able to learn and see that, yes, if this person is able to do such things, so can I. I think that whole confidence started building it up, and we were able to see that the adoption of the solutions, the adoption of the platforms became much more easier. Because we had one challenge. One challenge was, for us, when we were choosing and figuring it out, that is it indeed possible to, provide all the medical equipments, gadgets, smartphones to a health worker who is just like a village woman and perform all the activities, versus a much more simpler method, which is engaging a college student or maybe somebody and can venture out because the person does not need to be trained on technology or things like that. But the major challenge was, imagine a college student or anybody outsider walking into a village and then knocking on a patient's door, and the pregnant mother opens up. And do you think that the pregnant mother would be willing or comfortable to share all the questions to a person who is unknown to him, to her? Obviously not. So that was the major challenge, but we were able to flip that out, wherein we were able to make these community health workers empowered through technology. And those journeys has not been very easy, I would say. It was extremely frustrating on the ground. Even that whole design, for example, the smartphones were not designed to work in very difficult terrains. There are problems of heat, sweat, dust. Like the moment the temperature would shoot beyond 40 degrees, the phone would hang, and there were problems related to dust and other challenges. But over the period, we were able to figure it out that, what kind of model, what kind of design, which phones were able to sustain throughout the day or at least several hours, so that the person is able to complete or finish all the tasks. So these are the design related things which we were figuring it out. And if you see, what we were able to try and do is that we were doing the design bottoms up, not a top down. In many cases, in a country like India, we love solutions which is there in US, we love solutions which is there in some of the developing nations, and we try to adopt that, okay, if the solution is available in such developing nations, so can we. But India is a country, and so many developing nations are very different in many ways. That is where we were able to design solutions bottoms up, figuring it out, what is the psychology of a mother, what is the psychology of a community health worker when they are actually looking into the platform, when they are actually looking into the application. Unless and until you are able to get deeper into the minds of these people, no matter how much of techie gizmos that you have, you will not be able to break into that jinx. That is where the fundamentals which you are trying to solve. And that is how we were able to transform through that journey, wherein the adoption of the community was at the center of the whole design approach.
Just a related sort of a question to Shujoy is that definitely, the trust factor, since the community health worker was from the same place. So even if she comes with a notepad or with a gadget, it doesn't matter for the mother to be comfortable with her. Do you think technology, it has an effect on the behavior of the client or the pregnant woman or anybody, a patient? Because I think the data somebody is measuring, sort of a real time. Okay, so and maybe I don't know what's the protocol, like they are communicating with the lady or to the patient then and there. So some sort of an direct sort of a result, like they don't have to wait for result or go to a place. And sometimes the doctors are very busy; they don't explain to them properly what the other. So do you think there was some sort of behavior, there was some sort of a comfort, or it took time for them also to adjust, okay, to this new sort of technology?
I would say, and we have many examples wherein we have seen, even there was a 70-year-old lady, she was actually uneducated, and we were doing some interventions wherein we brought in the autorefractometer, which is the computerized eye checkup, in a camp setting, and the power went off. And so we kind of persuaded that lady that the power might come after several hours. Why didn't you go for a manual checkup? You would not believe or imagine that the lady waited for the entire period for the power to come so that she could do her computerized eye checkup, and she was uneducated. So that belief made, and in the communities, that is how it is, wherein even if they don't understand the language of technology, but they would understand the trust factor that this technology is good for me. And I think that is the whole fundamental we are trying to solve. The moment we try to bring in any new devices and we are trying to do any checkups to the patients with some new gadgets or technology, we would see the spark in their eyes that yes, I think I am at good hands. I would be treated, I would be cared, I am being cared. I think that is the whole experience that we have been able to do. And in that fashion, I would say the welcoming nature of the patients and the communities at large to understand and adopt technology. Why do you think that the smartphone penetration was, such a huge momentum, a leap that it was able to do? Because it's about technology, it's about the belief that technology might be good for them in many ways, and especially within the healthcare. They have been all grown up with very rudimentary kind of treatment, but with the emergence of knowledge and education, which is going to the youngsters who are going out, studying in the colleges, and maybe some of them even in the universities, they are bringing such information to their parents. They are bringing information to the communities that the times has changed. It is important to understand and adopt to that change in terms of technology, in terms of many other things, that maybe this is something good for us. And I think that trust and belief is very, very important for the communities to adopt such things.
Wonderful. Now, Kevin, coming to you, we have so much of data now through the digital health. It's like in India, and one health worker collect 6,000 odd data from the community. We are sitting on a huge data set. That also sometimes people are seeing as a threat sort of a thing. They use we talk of privacy, the trust factor, and all. So when this whole digital health is booming in India, what are the some 1, 2, 3 key things a system, both where I talk of the private system, and the government system? What are the key things that needs to be taken care when you are using so much of personal data, I would say?
Yeah, I almost kind of equate it to at the beginning with the internet, right? Where at the beginning we weren't using it very much. And as it started to scale and businesses were using, et cetera, we realized there was a huge security component that we needed to put in place. And so with the healthcare records and the healthcare information, it's something that we need to look at right from the very beginning, is to create an end-to-end encrypted system where there's no vulnerability from that information. Most people, if you talk to them, the most important information that they have is their health information, almost more important than their financial information. And so, there's a huge amount of vulnerability, and not just within this community, but even within our own lives. And the thought of how that information could be used for nefarious purposes is something that I think people worry about. So, as an example, if someone finds out that your DNA is disposed to have a certain health issue, will my insurance company not cover me, or will they charge me more? Because I have this predisposition towards a particular health situation, or I live in a particular environment that creates, a more a situation that's more likely. This is aided telehealth. That's a huge factor. When we really started to expand telehealth in the United States and most of the world as a result of COVID. But what ended up happening at the beginning, telehealth was supposed to be an answer for us to reach the last mile. But that's not what happened at the beginning. It was primarily delivered for those that are rich, wealthy, and well-educated. So for myself, as an example, it's like, this is the best thing ever. I don't have to go to the doctor for my annual checkup. I'll just get online and do my checkup, and I left a very satisfied person. But I'm also the person that's married to a doctor who gets on the internet and looks for things when I'm having a problem. And so I'm very well educated about my health. My mother and father-in-law, who live in a small town of 60, they didn't get health care for a year. There was no way to get them health care, and they were very uncomfortable with getting online and talking to a doctor by themselves from their computer, from their home. This is where the aided telehealth is so important for our more marginalized communities. And those marginalized communities are the Sunderbans here, but they could be just as simple as the elderly in any place, or the immigrants that are in any location that are really unlikely to go use a telehealth facility without it being aided from a language barrier, from just uncomfortable with technology. And that's where the technology, if it's used as a tool, becomes so powerful. In your example with the elderly woman with the eyes, is that she grasped the concept that it wasn't replacing the doctor, that tool was the best tool. And so she wanted to use that tool, not the other tool that she knew was not going to give her the best result. But it probably wouldn't have happened if we had asked her to use the tool in replacement of the human. And it became the tool itself. Thank you.
Yeah, I think sometimes, the choice, like in US, you have the choice of both doing things. But sometimes there is not much choice here. Like if there is no doctor or ANM, other facilities are not there and they have to travel a distance. I think this tool, what we are talking of, come to an end.
Yes.
So Shuja, just coming to the thing, the data when you're collecting, the CHWs, our community health workers are collecting. So is there a way this data, like if they want to do some follow-up visit, they are going to Bashanti District Hospital and all. Is there those data, because they have to then again have to do the test there. There is some connection with the government system, their result, they can take it up there.
Yeah, right now in some of the geographies like in Jharkhand, which we are working with Mark for Mothers, which is on the integrated primary health care for maternal health. Our community health workers are actually working in close coordination with the ASHAs and the ANM. So it's like a cross linkage between our system and the government system, so to say. But at the same time, what we are actually pushing for is, like for example, we are now, trying to integrate with NHA, National Health Authority, and there is a big push, as we are discussing with several of the state governments, wherein you would know that the government systems, like even if the doctor is writing a prescription, the diagnostics and others could be fulfilled only not more than 20% within a government system. So that means that the patient might have to go out for the remaining 80% of the treatment. And when that happens, in most of the cases, the patient is actually leaving the system. So it's extremely difficult for any doctors or even any key decision makers to figure it out that okay, within the government systems, the treatment, these were the things that were happening, but outside of the system, when the patient is moving out of the system, what actually happens? And that is where we are actually pushing for something called as an integrated primary care model, wherein the objective is that no matter wherever the patient is, within the public or within the private space, what kind of treatment that they have been given, they are always within that system. And if we are able to achieve that, again, that's not an easy feat to achieve. If we are able to achieve that, and I'm sure that we will be able to do, that means the patient would be able to decide where he or she can go for the treatment. And I think that strength or that empowerment has to be given to the patients and not to anybody else, because ultimately it's his or her health which is, and the person has the right to decide where the treatment and how that treatment needs to be given. And unless and until that cross linkage of the data, the seamless referrals happens, it's not possible. If I try to do a synonym of a finance sector, so to say, we have public banks, we have private banks, but when you are drawing money from your SBI card from an Axis Bank ATM, you are able to do, or a vice versa, right? But how and why it is not yet possible in this case, because India is coming up with NDHM, National Digital Health Mission. I also sit on the National Core Committee of CII, IT and ITS. We are doing discussions with different, principal secretaries and others. India as a country, I would say, if you look at the UID or the Aadhaar card, the number of data points are very few, only less than 6, 7, 8. But if you look at the healthcare, the data is moving from a patient to a community health worker to a doctor, at a village level, block level, district level, and even a state level. So it's way more complex. Or even if you imagine that if a patient with a gynec information goes to a diabetologist, does the diabetologist have the right to see information only about the diabetes and related things and not anything related to gynec information? So there are a lot of data privacy also which is built around that, and for that we work with Microsoft. We were one of the 7 to create a data privacy framework, meaning that if we want to create visualization of the data wherein we are not I would say, and of course with the cascading of the PII, patient identifiable information, it is indeed possible to provide such information. So when, in this case also, if you really think that the patient data has to do the seamless linkage between the public and the private, the health data privacy would be of paramount importance. So we have to create such frameworks in place before we can fully scale it up.
This, I think the discussion, we can just quickly turn on video of Professor Shumon Chakraborty, who has talked the acceptability of the community, how to build a trust and acceptance at the grassroots level, and especially in the context of Sundarban. Reaching the last mile, he has given his view about this whole issue of trust among the community, how you can bridge the gap.
First of all, I express my extremely sincere gratitude to the organizers of this event for inviting me to share my views on the different aspects of digital innovations in healthcare, and typically healthcare for the last mile, with particular reference to the context of Sundarban. I will briefly present some of my viewpoints on this particular matter, and to do so, what I intend to showcase is the fact that the digital health model is not something what is grossly new. It has been existing over the years. In the common digital health units that now India and several other countries have standardized to a great extent is the concept of a digital health clinic. The digital health clinic could be a brick and mortar room, or it could even be a mobile unit, such as a bicycle or a motorized bike, among several others. In the context of Sundarbans, this mobile unit obviously becomes the launch. So the whole idea is that the patient approaches the clinic. The clinic, by definition, could be the brick and mortar unit, or in a functional sense, it could even be the bicycle on which is riding a frontline health worker. The frontline health worker has a digital tool. It could be a smartphone, it could be a tab, and using that, the frontline health worker enters the record, the electronic health record, which is partly from the input that is derived from the patient, and very commonly there are menu-driven software where the frontline health worker has to check the correct option. In addition, the healthcare worker may record certain essential data like non-invasive data such as temperature, blood pressure, pulse rate, oxygen saturation rate, among others. And all those data, which I would say broadly include the patient-specific health data and some health metadata, altogether is reviewed by the doctor. And the doctor may interact with the patient as well as the health worker as per need, as per feasibility, if more interrogation and information exchange is needed. I have deliberately not mentioned whether the doctor is physical or remote. This model works both with physical doctor and remote doctor. With the remote doctor, there are inevitable limitations, but the scalability is so huge that it can bring a large number of people who are otherwise unattended because of the lack of availability of doctor to basic screening and clinical recommendation. The doctor reviews the inputs and recommends, and the patient, if the patient is not getting the service for free, maybe a minimal user fee has to be paid, and there is a formal exit interview of the patient. So if you see, this appears to be a very nice model in concept, even in practice, and it is existing at many places. If you consider now that what is the, very critically, what has been the success of this model and what is that extra pitch point which is missing to make the success even more imperative and effective. The backbones of all these technologies are human resources, in this case minimally trained rural youth, a decision support algorithm which is commonly interfaced by a software or an app, proven diagnostic technologies which are supposed to be made available and accessible, and the availability of remote doctors who will make up for the non-availability of physical doctors at remote locations.
I think this model is really like he tried to explain what are the different approaches. But one of the things that was I feel it was missing was the equity angle. Like one of the key objective of digital health is that it should be equitable. So, and people, fragile areas like Sundarbans and all, where accessibility is a very important issue. So I think digital health can really bridge that gap. I think here Priya's perspective on the issue of equity, how digital health can bridge that gap. If you can just play that, I think number 3 question. Definitely, it should be like affordable, accessible, and equitable. I think these are the any healthcare that we talk of. We should touch.
Digital technology enable us to extend into the social, cultural, and economic positions for equitable healthcare access, of course, and it's already doing so. But digital innovators have an unprecedented opportunity right now, even as you're sitting in Sundarbans, to think more carefully about health equity and develop new solutions to entrenched health problems. And to do this, they must begin by considering how inequities in access limit the number of reachable communities, and by determining which dimension of health inequity their solution could address. So, there are health inequities in access, in care provision, in financing, and also in the use of technology itself. And equity needs to also be understood in how we bridge digital divides. If you are addressing an elderly community or a community with low digital literacy, that has to be addressed as well. So, in order to kind of build an equitable digital solution pathway, there are a couple of thoughts I could put forward for this forum to maybe even discuss. One is to embed the notion of equity in product development itself. So, digital innovators can prioritize diversity and inclusion in every step when they are developing a product for a community or addressing a challenge. So, from initial research and concept design to testing as well as implementation. The second point is collaborating with communities and patients. By listening to and working with patients, innovators can better understand the intricacies of a patient's journey through a particular community, which allows them to develop solutions with greater sensitivity. So digital design will play an increasing role in your ability to penetrate communities as well as integrate with health systems. The third is to integrate equity in commercialization itself. So digital innovators must ensure that educational materials, instructions are inclusive and the entire patient or community population by considering and addressing factors like health literacy as well as language barriers. So you have to understand the population you are addressing, their ability to use digital tools and technologies, and their understanding of these technologies in how it would empower them to not only monitor their own health outcomes, but the outcomes of others in the communities that they are part of.
So I think this perspective is very much important when we are developing any product. So that comes through you, Kevin. Do you think that this digital technology can improve this equitable access? What are the sort of the bottlenecks that you can foresee in this Sundarban context, which your team needs to take into account when they are step by step they are developing a model or an intervention?
I think there's a piece that she talks about right from the beginning in terms of with the product development to have that information gathering from the community and truly accessing their needs before you begin. There's a real danger, and it was beautiful to see that CJ recognizes that as technologists, we can get enamored with the product itself and tend to focus a little bit more on the features and functionality versus the real value that we're trying to deliver to the individual. So I think that it's gathering that information early and then building the product there versus you build the product and then you try to make it work for the individuals that you're serving. I think she touched on that briefly, which is perfect. So I would bring that up again. That's very, very important to start with we've heard it earlier in the earlier discussions for the community at the center, and that product development stage should be there as well. It also comes into, besides the technology piece, it also comes into the healthcare solutions that you're trying to solve. It was mentioned earlier that it's make sure the solutions are relevant to that community. So, example, cancer is a really terrible disease. That may not be the right solution to try to solve for in this community. It may not be relevant to them. Then the solutions might be too expensive or complex to solve. So start with the areas that are most relevant to them. I heard last night by listening to the women in our community that their number one thing was around healthcare, prenatal, postnatal healthcare was very, very important to them. That's a good place to start. And then you start layering on based on what other solutions that they look for. So that's starting with the community at the center. And so when I was listening to especially the last woman explain, it's really making sure the solution has the community at the center all the way through that process. And you're going to get the best outcomes.
We will come back to this whole concept of community at the center. Before that, I won't say digress, but digital health, it's not always good. Like there's a negative perspective also. The whole, we have this, like from the morning, we wake up first thing, we just do this. And the social media. So it has and having, for last, I think, few years, people have been discussing about the stress. Not only the youth, I think the aged people like us also. How many likes you have got? What are the retweets you have got? The social media has really created a havoc on mental health. So digital media, digital health also, or the digital media, I would say, has a negative impact also. So I think a very nice perspective Professor Oshihiro has given about what are the digital innovation can contribute to mental health. It has created an havoc, but also at the perspective is that how it can really streamline or give an impetus for the mental health. Sometimes I think this issue also here, obviously the issue of child labor, childbirth or eye issue, all the physical thing, but mental health, digital media can come into an aid. So I think those things also slowly, I think when you develop product and innovation, you can look into. I think number one question. Yeah.
Okay, thank you very much for asking the important questions. There's a big, as I said, it's a big issues also in Japan. By the influence of the digital technology, and the people in Japan, 40% of the adults, the people in Japan are using 4 hours a day, and the teenagers are using the smartphone almost 4 or 5 hours a day, which is a lot. And that is almost 20%, more than 20% of the waking hours. Many hours, our brain is hacked by the smartphone, and I think it's like an infodemic, as the WHO says. Lots of information is coming to our brain, and of course, COVID-19 makes it worse. But I think there's a lot of positive way as well, positive side, such as increasing the remote work. We can work and study from the home. That is good side. And we can collect information from the website. We can connect with the friends and family. That is okay. And some students who are really has a mental disorder like autism or the anxiety disorder, those students before pandemic they could not go to school, but because of this online circumstances, they can attend class, and that's a good part. I think the positive side, but I think there is a lot of negative side as well due to the digital technology, and it's interesting that as the GDP increases, the number of the people who get mental stresses also increases. Like you see the US, in the US, I think it's almost 40% of the population has some kind of disorder, anxiety disorder or like depression, and it's because they are the richest country in the world, and they must have a lot of money and materially and physically rich, but in their mind is really, difficult, no? So well-being is more crucial, I think, in modern world. So I don't say that it's all because of the digital technology, but some part it may affect to it. So I believe this is because our human brain, our human are not get used to using too much digital technology in the process of human evolution biologically, right? So I think we have become too independent on digital technology, which is really abnormal situation. Yeah, that's what I think. Okay, thank you very much for asking the important question.
How much time we have for this session? Because I think this next question, he gives sort of a solution. What are the different psychological indices which needs to be built as part of digital health? That will be interesting because he cited the problem. So let us hear some of the solution that, yeah. Okay, I think, yeah, it will be interesting to, yeah.
Yeah, I think this is a very good question and a very important question. But I think the first priority for the mental health is to access to the specialist. To the psychiatrist or psychotherapist or the medical care, right? That is the most important part. And the specialist examined the degree of the illness and based on the cognitive or maybe the emotional behaviors. And they also check their private personal thoughts or environment, right? The social context. I think, but the main problem is that the many the people, especially young people who has a lot of stresses, they never go to clinic until they get really bad. And yeah, that happens in Japan too. And I think we must connect these people to the specialist or to the clinic at an early stage. And that is important. And then for that, digital tool is really useful because lots of we cannot live without smartphone nowadays, right? And the smartphone, the digital technology can provide the remote medical treatment, telemedicine, or sometimes it can use the AI consulting, like counseling or psychological support is possible. And also proactive, approach to conduct those regular health checkups.
Before I throw the floor open, just last question. We have been talking of community at the center. So the products that you have been testing, the intervention. So how you are sort of measuring those, the user friendliness, the process. So what are the frequency, and so that you can also tweak the product also, because it's just not something you are finalizing the thing. So what is the plan and how you are approaching the whole measurement concept?
Yeah, thank you very much. In the last several years, we have been working with more than, I think, close to 25, 30 odd devices. And we have actually helped 4 device companies from US get even FDA approvals. Whenever we get a new device with a certain objective in place, what we do is that we test that device along with already a certified device. So we map the entire journey of the device in terms of user friendliness, feasibility, portability, the cost, price, and everything before they can be fully deployed on the ground and commercially viable. Just to give a quick example, so we have 2 friends coming in from all the way from IIT Kharagpur. So as I mentioned in my last session, that we are collaborating for a device called AP1, which can give the real-time data when the patient is in transit. And so this iCare is actually emerging as a platform to connect any new device innovation which is happening in a lab setting all the way up to before it is commercially made available. And there are a lot of nuances to that, because let's say the weight of a medic bag cannot be more than 3.5 kgs at max. So within that 3.5 kgs, our challenge is always that how much of the tests that the health worker will be able to do. So here, even the device weight, the functionality, the usage, the usability, all that comes into play before we are getting to test. iCare has also signed an official agreement with ACT, which is formed by a body of top 10 startup unicorns and led by Dr. Nachiket Moore as a guidance. What we are also doing is iCare can become the evaluating partner devices, because of our large catchment area. We would be able to test the devices in terms of all these aspects, and it is pretty much important. And even I have been part of many platforms, and even the youngsters, they are coming up with many of the devices. And in my last question, I was mentioning that in many cases the students or the youngsters, they get very fascinated about loading a lot of features and the functionalities, bypassing or ignoring the usability perspective. That's very, very important. So in fact, the whole user mapping journey is extremely important for the device innovations to play a key role and become fully adopted.
So I know it was like last, I think 3 hours. It's quite too much of information we have. So any thoughts, any suggestion? Not only, yeah, Parvita.
I'm taking off from audience. So if we are focusing on prevention, we need to understand mental health from somewhat larger than being free of any disease or disorder as positive well-being. So how can digital health build into that? I really am curious, with a special focus on youngsters and adolescents, that the concept of mental health changes from being free from disorders and diseases, mental disorders and diseases, to a state of well-being, mental and social well-being. How do we change that? How do we use digital tools? And because the youngsters are very much into that, so how can we leverage that to change this concept of mental health towards a more positive aspect? It's a question to everyone here. Thank you.
Yeah, I think couple of things definitely can be done. Anything, I would say anything if you are trying to do with a discipline in mind, I think then that's definitely very, very important, because here we are not trying to say that the smartphones are bad and now you can completely ignore that. That is not the case. The important thing is when to start, and at your mind you have to see and think when to stop. The problem is, youngsters and even adults, like, we know when to start by suggestion.
it is just not digital way. I think the awareness and at part of school curriculum, when where to stop it, that is quite important. Everything cannot be digitized to teach people. Yeah.
This may be worth a follow-up conversation, but just something to think about that in response, how I is looking at the impact of relationships and connections, and is there ways to influence or open up access to healthy relationships and healthy connections? So there's a lot of people have come, amazing people, great Indians who have come from the Sundarbans, but they're not here now. The number of men that are gone here, positive role models that are gone here, the people that have opportunities to go do other things, that take advantage of those opportunities, but they're geographically now separated from here. And you think about in the U.S., there's a very positive impact that comes from something called Big Brothers, Big Sisters. Right? Is there a platform or a way of helping to facilitate or encourage those connections, where you have a mentor, or you have someone that's speaking about their life experience in a positive, inspiring way, again, or encouraging and forming relationships, whether it's with mentors or with peers, that are healthy and really good and supportive relationships, as opposed to a lot of the relationships I think online where that's coming from is them being more extractive than they are supportive. It might be an interesting thing to look at as we look at the next year, whether there's a way through Recanter or others to help just take a look at those, encouraging or forming some of those relationships.
Yeah, sort of a positive deviance, if you say. It's learning, yeah. But you can also. Yeah.
As Sujoy sir mentioned, that discipline is important. So that is where we get to know when to stop and when we started. So the problem is the adolescents or even the adults, they get eluded into that social media dopamine boost, and they are stuck there. So this also the second comment, like a healthy relationship needs to be built. So what I feel from a very close experience of mental health is being opening to the family or the close persons talking about mental health. And the other thing that matters is the social stigma. So basically, the thing is, the adolescents or the young adults who need to be made aware of the medical health conditions. Because what happens, from a very close experience of mental health, what happens is the person is not aware that he or she is having some issue until they are out of that situation. So here the role of education comes, and the stringent education system that we have, I'm not complaining about it. The methods the methods in which the information is provided to the larger public needs some innovation so that it can be as catchy as the reels that we watch.
Quite a nice and different perspective. So I think definitely we are not ending this discussion to this 1 hour, and as I mentioned in the beginning, digital health is the soul of IQRA. So the way ahead and all we can discuss, like 1.5 days we still we have ahead. So with that, thank you so much, and especially our 3 experts who couldn't be with us. I think that we can be in touch with them as this collaborative journey, keeping community at the center, we can get through into. Thank you so much.